It's my pleasure to introduce Dr. Santhan Gopal, who actually does not need any introduction. Very uncharacteristically, he is talking on something which is not his, probably the strength, but they're all his strengths. Yeah, true. But I think of late, amblyopia has taken a lot of his time, and
Okay.
but
Thank you.
he can do justice to any of the topics in this whole symposium. So I'm going to ask him to talk about what's new in concomitant strabismus.
Thank you very much, Sumita, and I am thankful to the AIOC for all this invitation. I'm going to talk about something different. You have to be different. So I talk something different. I'm sure you all have treated all these patients, isotropia, operate on medial rectus, exotropia, operate on lateral rectus, blah, blah, blah. But look at this child. She is cheating you. Huh? Can you see this child? You look at, take one look, you think, straight-eyed. But then draw the attention of the child. So there is something there. So what I am trying to, look at this child. Initially, with glasses, there is a head tilt. I thought, no problem, this must be DVD associated. After some time of wearing glasses, the eye goes the other way. So what is it that makes these children look different at different times of the day? The thing which makes them look different, I'll come to that in a few seconds. Concomitant isotropia means associated with squint. It has no meaning. The ophthalmologists have understood the meaning of concomitant differently compared to what dictionary says. Concomitant means the squint is same in all directions of gaze. That's all. That's all we have understood. How often the squint is same in all directions of gaze? Never. If you look up, the eyes go out. If you look down, the eyes go out. And if you look nearer, the eyes come in. So it has no meaning at all. So we need to redefine everything. We need to redefine amblyopia. We need to redefine squint. We need to redefine the whole concept. Okay? Now that's what I'm coming to. As a clinician, you are happy. Isotropia operate on the medial rectus. Have you ever proved that in isotropia the medial rectus is strong? Never. You are operating and somehow the eye is getting straight and somehow the brain compensates for all your mistakes and the eye becomes straight and they become binocular also over a period of time. And so what is it that I am doing with Orthoptic? I am doing with Orthoptic few things. Number one, I am trying to draw the attention of the attention center in the brain. There is an attention center in the parietal lobe in the brain. So by using Orthoptic, I am stimulating the attention center in the brain via the magnocellular stimulation. The magnocellular pathway stimulates the attention center in the brain, and when the eye makes a saccadic eye movement reflexly, a part of the thing goes down into the occipital lobe and stimulates the occipital lobe. And this part which is coming down is what is called as top-down impulses. Okay? This has never been used ever in the treatment of amblyopia, and they have never looked at it properly because the attention center has received least attention. Somehow or the other, for so many years, the attention center has not received any attention at all. If you do this, the attention center improves. You pinch the ears, automatically the attention center improves. So what happens is, in the parietal lobe, there is a sensory motor integration. So squint is essentially a problem of sensory motor integration. Okay? And I have stopped operating on intermittent divergent squint. I have stopped operating on dissociated vertical deviation. And esotropia gets reduced by more than 50% in many of the patients, so I need to operate less on esotropia. I have stopped operating on fourth nerve palsies altogether because the head posture improves with orthoptic treatment and they are symptom free. and they don't want surgery. I have lost money because I don't operate on them. I have stopped operating on acquired sixth nerve palsies and do all those things, do this, do that muscle, bring it here, bring it there, because the top-down impulses travel to the superior colliculus and then they go on to the sixth nerve and improve the amount of the squint. So don't be under the impression orthoptic only treats the sensory aspects. No, it treats sensory and motor aspects, and that happens because in the parietal lobe there is a sensory motor integration which happens. Not only sensory motor integration but also sympathetic and parasympathetic integration happens in the parietal lobe. And many of the cerebral palsy children, what I have noticed is their drooling disappears within 1 week of orthoptic treatment. I never understood why should drool. The patient came and told, mother said, sir, I don't know what magic you have done, she is not drooling anymore. I said that doesn't make sense to me. Then I went back into the literature and then I realized in 1985 there is a paper by Ayres sensory motor integration theory from France. She is not an ophthalmologist. She wrote that there is a homogeneous stimulation of sympathetic and parasympathetic stimuli once the parietal cortex is stimulated, and therefore if the sympathetic overaction is more, the child will cry and scream. If the parasympathetic overaction is more, the child will have drooling, and because of the homogenization of these two, the symptoms disappear. Amblyopia is essentially an attention deficit disorder. So what I am trying to do with amblyopia treatment is to improve the attention of the attention center in the parietal lobe. Yesterday Pradeep asked me, "Arey yaar, tum kya bol rahe ho? Magnocellular cells ko aur parvocellular cells connection kidhar hai?" I said, very simple. It is there. It is there in the parietal lobe. Parietal lobe is connected. And when the magnocellular cells are stimulated, there is an early parietal cortical activation even before the V1 gets stimulated. So what it does basically is it top-down impulses makes the magnocellular and parvocellular cells come in a sequence. The stimulation from the retina should go to the occipital cortex within 150 milliseconds of the top-down impulses coming from parietal lobe. Then there is a rapid fast forwarding of impulses from the V1 to the temporal cortex, and therefore the vision improves. With Orthoptic, the vision improves within 2 to 3 sessions, the vision improves. Maybe not 6, but certainly it improves by 2-3 lines. You will be surprised. After one treatment, suddenly child reads 618 line from 660. What is this? Is this some magic? No. That is the brain working. It is the brain. So what we have always concentrated on is on the visual acuity value of the receptor, and we have concentrated on the directional value, but we have never bothered about the motor value of the retinal receptor. This is what improves in the motor aspect of treatment in orthoptic. That's why the squint gets reduced. Intermittent divergent squint, you have so many indications for operation. Nowadays, I have stopped operating intermittent divergent squint because they don't need surgery at all, except if they have a marked inferior oblique overaction. That also I have my own doubts whether they need surgery, but over a period of time, I will let you know. Fourth nerve, I don't operate at all. It's so very easy to do the inferior oblique recession, but I have stopped operating on fourth nerve. Sixth nerve also I have reduced. And the only way, last point I would like to say is this is how an eye causes problems throughout the brain in amblyopia. So we have been looking at only eye and a part of V1. We have never looked at the extra striate area which has much more problems due to amblyopia. And there are motor aspects to it. And one last thing. We have not paid attention to the attention area. And lastly, where is that? Okay, he has not updated it. Okay, these are the things which I have been doing perfectly all right. And magnocellular stimulation leads to early parietal lobe stimulation, and this in turn stimulates the attention area in the parietal lobe, and the stimulation of the attention area in the parietal lobe in turn stimulates the V1 at level 4C beta, which receives the parvocellular input. And if the parvocellular input received by the level 4C beta comes within 150 milliseconds of the top-down impulses, vision improves rapidly. Now, patching works because of this, but in patching, the ocular movement is not necessarily so precise. When you patch the eye, this eye may be moving randomly, and occasionally it may come before that, and so the vision improves. Thank you very much.
Thank you, sir. You made us all think differently, and yes, think a lot. And I'm sure this room is full of pediatric ophthalmologists, all eminent pediatric ophthalmologists. So a lot of them will take your thoughts forward, and we will see more research on this.
Incidentally, I have sold more than 65 machines, and many people, Shreya is using it, and all they came and said is it works like magic, which is, I'm very happy they came and said it works like magic. They have seen many patients, they have treated many patients. Unfortunately, they don't want to publish it because they say we have no time to publish.
Actually, I totally agree that you have, as always, you kind of stimulate us to think differently. And it is not an easy task to change so many concepts that people have been doing for so many years. And it's really creditable and appreciable that you have been trying to hammer your point, and I'm sure it will go a long way.